Hi, welcome back to A Dose of Reality. This is episode 3, Understanding the System and Treating Substance Use Disorders from the Inside Out. I'm Abby, and today we're here with Amy Maurizio and Layne Turner. Amy is the Director of Operations at St. Luke's, and Layne is a Network Coordinator for Substance Use Disorder Programs at St. Luke's. We're here to have real, honest conversations about what's working, what's broken, and how people are making a change from the inside. Amy, do you want to start with just telling us why you're in this field and what getting into this role kind of looks like for you?
Sure. So I've worked in substance use disorder services since the late 90s, pretty much in many different capacities, as a case manager, as a therapist, as a supervisor, and now as part of a health system with St. Luke's. So I've had varied experience working directly with the patients that we serve, as well as the staff who are implementing the services that we offer, in addition to now focusing on integrated care within a health system.
Nice. So you've gotten to really see like all aspects of what substance use disorder treatment looks like from a variety of angles, which is, I think, really important. Layne, do you want to share your background and why you're here and what that looks like for you?
Sure. My background is a little bit varied. I've been at St. Luke's for coming up to 5 years. Prior to that, I was a drug and alcohol administrator for the county of Lehigh.
Okay.
So coming over to St. Luke's, I was able to begin looking at their systems similar to the county operation system that I oversaw in Lehigh. I'm looking at drug identification in patients or individuals that we serve, their access to treatment, their recovery support, and the actual treatment itself. So being able to come over to St. Luke's and work with a healthcare organization and begin kind of creating those same capacities within the emergency departments, within inpatient medical and our outpatient offices, there's really a great overlap between working for the county and now working for St. Luke's.
Yeah, I feel like that's probably an interesting perspective for you to have also because you went from one entity of this to kind of a larger scale, I guess. I know St. Luke's is a really big operation, especially. I mean, it's working its way into this area. We have the St. Luke's Hospital here. I don't think we have the substance use program in the Stroudsburg region itself, but I know that it's like stretching into this. How have you guys started to see shifts or trends in the hospital setting with substance use? I know you said that you've been working in the field since the 90s, Amy. So I think that is kind of the start of prescription drug use when that started to really become a problem. So how has that changed over your guys' course of work experience?
I think that in many ways, not just the hospital system, but the healthcare system, including primary care and specialty care, really at that time in the 90s had nothing to do with substance use disorders. You know, if somebody came into the emergency department seeking care, they likely would not leave there with the care that they're looking for. Fast forward to today, and I think that's very different. In all of our hospitals within the network, we have warm handoff programs, and we partner with organizations in the communities where the hospitals are located to connect individuals to treatment resources and other services that they may need to achieve recovery. And Layne did a lot of work on that within the St. Luke's network. When he first got here, he really got that up and running. So I don't know if you want to talk a little bit about that.
Yeah, if you want to tell us a little bit more about that and what it might look like for an individual who's kind of experiencing the warm handoff program or when they enter the hospital setting seeking that.
So we wanted to make the process as easy as possible, not only for the patient and the family, but also the medical team providing the support and wherever they're at. And so it's a process of being able to quickly identify a patient that is impacted by a substance use disorder, and then following a very specific script that's kind of mapped in the medical record that we use. We use Epic, that it will tell the provider, step 1, step 2, step 3. And so it's done through best practice advisories where actually pops up on a provider screen and tells them what to do next. So we want to make that process easy and quick, but we also wanted to make it useful because I think substance use disorder was always kind of like an individual silo and treated as an individual silo. But now with the population we have, we understand that substance use affects all populations, whether it's cardiology, pulmonology, orthopedic care, pediatrics. It really knows no boundaries. And so being able to create a system that will cross those disciplinary sectors was really key for St. Luke's and being able to provide the best service possible for our patients, no matter what setting they're in.
So what does the warm handoff program look like if I, let's say, walked into the emergency room experiencing some sort of substance use problem, and I saw a provider in the St. Luke's hospital setting, and they were to refer me to the warm handoff program, if that's how that works? What does that sort of look like?
So the provider would put a consult order into the Epic system that would then trigger the initiation of the warm handoff service. So again, depending on the community in which the hospital is located, we would then contact that organization. So if you're talking about Carbon Monroe or Pike counties, we would contact the CMP Drug and Alcohol, and then their worker would go out and meet with the patient, conduct an assessment, look at what services the person is interested in, and then would connect them with those services, ideally directly from the emergency department. So if the individual wanted to go to rehab, they would arrange that rehab transition from the emergency department. Certainly there's caveats to that where it might take longer, like if somebody has VA benefits, that tends to take a little bit more time because they need to go to a VA hospital. But if it's someone who has, Medicaid services, generally that transition can be made pretty quickly to a treatment provider in the community.
What sort of shifts have you seen in substance use itself throughout working in the hospital setting? I know a lot of problems that we're seeing in the drug supply itself, it's contaminated with fentanyl. So what does that look like kind of on your guys' end? Are you seeing similar trends?
Unless you are actually creating or growing your substance in your backyard, nothing is safe. Everything is contaminated. Everything is a polysubstance use that's in the community, whether it's xylazine, medetonidine, fentanyl. You never really know what you're buying. If you go to a vape shop, gas station, even get the K2, the Kratom, the K2 has different variants of whatever, depending on how that run of chemicals were made up. And so nothing is safe. And so we're seeing more individuals coming in with very unique presentations that may vary, that may not be what we would expect to see for somebody who says that they typically would use methamphetamines, but they were revived by Narcan. So that would tell you opiates is present. And so it presents this very unique problem, and quickly identifying really what is the root cause or what is the substance that individual is using. Once we determine that, we're able to then quickly determine what is the best course of action as far as treatment. Is a detoxification, withdrawal management needed? Is a straight residential treatment that's needed based upon the substance? So it's becoming a little bit more problematic because of the supply chain. I think the other thing is that we're seeing too, and I'm sure Amy can attest to that, is that patients are coming in sicker than what they did even 7-8 years ago, 5 years ago. Not sure if it's a result of COVID and people being more isolated and not following through with primary care appointments and letting things kind of lapse. But the patients that we're getting now tend to have more complicated medical issues that are co-occurring and coexisting at the same time. And we're also seeing an aging population where it's not uncommon that we're getting 65, 72, 78-year-olds that are coming in after chronic use that haven't had any type of treatment episodes in their entire life, but now they're at this end. So it's a very unique patient population we're seeing now. Yeah,
that's interesting. Because I think a lot of the times when we think of an individual with a substance use disorder, we like to quickly think, 20s, 30s. So even you saying that you have this aging population with a substance use disorder and they're seeking assistance kind of also suggests that we're seeing large-scale changes in the population that's using, which we kind of knew that, but to even hear it from your perspective is interesting. I read something recently that said 9 out of 10 pills are contaminated with some substance other than what you think you're buying. So, I mean, what you just said is definitely a testament to that.
It's that easy. Oh, sorry. It's that easy when you can go on Amazon and buy a pill press machine and a stamping machine, and you can press any substance to make it look like a Percocet, like a Oxycontin, like a Vicodin, and sell it off the street as that product when it's something else. That it's really, you need $35 in an Amazon or Etsy account, and you can manufacture anything you really want.
Yeah, I think that's scary. A lot of the times, even for young kids, I know that I just had a conversation with a peer not too long ago, and we were talking about changes even in like the high school age group, which we like to say that they're experimenting, and most of the time that can be harmless, or it used to be harmless. But even in this area, we're seeing a lot of overdoses in that youth population because they're not consuming what they think they were purchasing. So I think it's important to get that information out, that 90% of the time what you think you're buying is not what you're going to end up with.
I think the other thing that complicates that a little bit is that because there's such rapid changes in the drug supply, the drug screening cannot keep up. And so, right now we're seeing presentations of medetomidine, and it's not being tested for. If you look out there, there's very few labs that are doing any sort of testing. There's currently no instant tests as of this time that can be done in the office. So I think that's another challenge, that as we move through the different contaminants that we're seeing in the drug supply, and even when you're talking about some of the substances that are being purchased at the smoke or vape shops, those things are hard to test for. So even as treatment providers or a hospital system, it's hard for us to really pinpoint what somebody is actually using.
Right. You mentioned like rapid tests. So I want to talk about the fentanyl test strips for just a second. I think that it'd be beneficial to have them legalized in this large scale setting, just because then people, if they have the initiative to test whatever substance they're using, they can make an informed choice as opposed to not having that opportunity. What is your stance on that from a healthcare provider perspective?
Oh, we're absolutely supportive of that. St. Luke's, as a network, both in our emergency departments and most of our primary care and our federally qualified health center lookalikes, do provide the testing strips for both xylazine and fentanyl to anybody that asks. We also provide the Narcan. We don't ask for a name. We don't ask for an ID. You want it. You want how many strips, and we will just give it to you. Our experience has been is that individuals who may be more cocaine and methamphetamine users are more likely to actually test their product because they don't have a tolerance for the opioids. So they really want to avoid fentanyl being adulterated into any of the product they're using. So they're worried about that overdose event.
Absolutely.
So they're more apt to actually take advantage of the testing strips and use it. But being able to push that information out and push that supply out into our community is very important to us.
So what would the process be if someone was looking to get the fentanyl test strips or the xylazine test strips from St. Luke's?
You'd just be able to come to any emergency department and ask for it. If you want them in more of a bulk supply, like 10 or more of the supplies, you would just email into, there's a number on the state's webpage where you'd be able to contact us, and we would be able to bulk supply not only Narcan, but any of the testing strips you want. So it's not unusual. Get requests for 50, 60, 70, supply at a time, and be able to provide that to community members, churches, youth groups, anybody who asks.
Yeah, that's good information to have. Thank you for that. What kind of systemic failures have you guys seen that kind of contribute to the substance use disorder problem that we're seeing and the overdose epidemic and all of those sorts of problems that we're having?
So I think one of the biggest things that creates a challenge for people looking to initiate recovery is really social determinants of health. Housing is a huge issue. Transportation is a huge issue. And the majority of individuals we see seeking care are homeless, whether that be truly homeless by the state definition or that they've been sort of couch surfing on friends' couches or living in random places. And it's really hard, to start your recovery without a stable place to live. And depending on the area that you live in, certainly in the Allentown area, transportation is a little bit more available than in this area, in Carbon, Monroe, or Pike counties, where that tends to be more of a challenge. So getting to outpatient treatment programs, getting to 12-step meetings or other support activities can be really challenging. I think supports for individuals as well. Oftentimes they struggle to find positive supports in their life, especially if they've burned some bridges with family and friends along the line. So I think that's a real challenge. In terms of treatment, I think I think we've made great strides in terms of connecting people with treatment. Like I mentioned before, 10 years ago in an ED, you wouldn't have been connected to services like you are today. And the reality is that when people are seeking treatment, the only place that isn't going to turn them away and that is open 24 hours a day is an emergency department. And so we really need to be able to meet people where they show up with sort of a no wrong door approach to care. And we've also been looking to work with some of the other specialties, like Layne mentioned before, with primary care, with specialty care, to ensure that they have the tools needed to also make those sort of warm handoffs to treatment. We did receive a grant, at St. Luke's to implement a case manager in a primary care practice in Lehighton.
Okay.
We expect that to be implemented around the first of the year. And so that's sort of our first step into Carbon County, and we hope to partner with, Jamie and the others in Carbon County to continue to support the recovery efforts here.
Have you seen a decrease in the stigma in the healthcare setting regarding substance use disorders?
I would definitely say that we've seen a perception shift.
Okay.
And then I think, stigma, I always have a difficult time with that word because we confuse stigma and also compassion fatigue, and we look at them very similarly. I think if you look at healthcare and police, both entities love people and they do their job to protect people, but they also get very tired of what they see on a day-to-day basis. So that compassion fatigue, I think, sometimes comes out as a stigmatizing type of attitude or response when it's really, we need to take personal care of ourselves, in this line of work. And so I don't want to confuse that with stigma, because I think too many times we, attribute one to the other. But as the perception change that the network has had over the last even 5 years has been dramatic. And I think the best initiator of change is to drop a change agent right in the middle of it. So we have certified recovery specialists that work on our EDs and our inpatient floors, and we take that individual in long-term recovery. They are a staff member of St. Luke's. We put them right there in the middle of the ED, working with the provider team, the treatment team on the inpatient side, working with the internal medicine team. And based upon that individual being there, it opens the doors for so much more conversation, modeling of behaviors, and understanding that recovery is not only possible, but it's achievable, and it should be open to everybody. And so that has really began shifting, I think, the trends in the network and really how they are looking at patients with a substance use disorder. And that has been, I think, very beneficial for St. Luke's to engage that recovery route.
Absolutely. That sounds like a major success. I want to circle back to the compassion fatigue a little bit. I feel like that could even be attributed as a systemic failure in the healthcare setting, just because we have these nurses and doctors and physicians and healthcare personnel working 12-hour plus shifts. And it's exhausting, especially when they don't have the resources to implement that self-care. So I think that that's definitely a shortcoming in that aspect. But I do really like the certified recovery specialist being in the hospital setting and showing patients, but also professionals, that recovery is possible. And like you said, it's achievable and it's standing right there in front of you. How does St. Luke's integrate mental health aspects with addiction treatment?
So I think we provide, obviously, services on the substance use disorder side as well as the mental health side. So we look to ensure that people are connected to the right services. We currently do have our residential program down in Sellersville at the Penn Foundation campus. That is a co-occurring program for adults ages 18 and over. So we do incorporate it there. But all of our outpatient programs, whether it be at Sacred Heart Hospital or in Sellersville, also are considered co-occurring capable programs. So we're able to treat both. We provide psychiatry care as part of those outpatient programs, in addition to the medication-assisted treatment that's also offered within those programs. And there's also access to other mental health services as well within the St. Luke's network that we are able to make referrals to as needed if they needed some more specialized care, whether it be an inpatient psychiatric unit or whether it be TMS therapy, we can make those referrals and connect people to care. And that's kind of the beauty of having that continuum of care, is that we have all of those resources at our fingertips.
Absolutely. You mentioned the medication-assisted treatment programs at St. Luke's. So can you just share a little bit more insight on that for anyone who's listening?
Sure. So we provide medication-assisted treatment currently in Allentown at the Sacred Heart campus in our outpatient share program. We also offer it in Sellersville. And Lehigh Medical Associates also offers medication-assisted treatment through CMP Drug and Alcohol to support individuals in that area who wish to use medication as part of their recovery. So an individual would need to connect with an assessment, and then from that assessment, if that is their choice, they would be able to initiate that medication with one of our providers.
Also in the EDs, we're able to do initiation of buprenorphine for all of our patients that come in. So it's not uncommon that they will consult with medical toxicology and do some type of microinduction for a patient with an opioid use disorder who is beginning to experience withdrawal symptoms. And we're able to stabilize the patient that way. And so that is available in all 13 of our EDs as well.
Okay, interesting. So you guys have mentioned a lot of really good things about the treatment that St. Luke's offers. If you want to go a little bit more in depth on how these treatment models are evolving and how they've changed to kind of encompass all of the new discoveries that we've had in the substance use disorder field over the last couple decades, I guess.
Yeah. Yeah, I think it certainly has come a very long way. I think, back when I started working in the field, there wasn't a lot of evidence-based care back then. The treatment services tended to be more punitive. There was a lot of legal involvement and, mandates by the legal system for treatment, rather than allowing the treatment team to kind of make decisions about the care that was being provided to someone. And so over the years, we've seen drastic changes. In the implementation of motivational interviewing, using stages of change to really help people understand what the change process looks like. Implementing cognitive behavioral therapy, dialectical behavioral therapy, and the DBT skills that really have been shown to be effective with this population. Also, I think it's really important to include families in the care, or if there aren't families, other support persons or individuals who are supportive of the individual seeking recovery. Case management, I mentioned social determinants of health before. Mm-hmm. We really have to look at the whole person and try to look at wellness, overall wellness, and not just the substance use disorder. You mentioned mental health. If someone does have a co-occurring mental health disorder, again, if we're not treating that at the same time that we're treating the substance use disorder, someone is going to go back to using substances to cope with their depression or whatever it might be. So we do train our staff, our clinicians, our nurses on all of the new evidence-based practices that are shown to be effective with this population. I think just to go back to the stigma piece, and one of the initiatives that St. Luke's has put into place is, training our hospital staff, emergency department staff, and others in motivational interviewing, so that when they are interacting with an individual with a substance use disorder, they know how to have those conversations and to ask the right questions and to show compassion and empathy, and not, using stigmatizing language when they're interacting with individuals. So it's important to do that not only in the actual treatment programs, but also with anyone who has a touch point with someone with a substance use disorder.
And one of the cool things in being able to marry the hospital-based, the physical health care, and Penn Foundation is a program that St. Luke created called the STAR program. So it stands for Sepsis Treatment and Addiction Recovery. So think of it as an infection that somebody would get as a result, typically, of injecting drug use. Mm-hmm. So I call it the itises, so osteomyelitis, endocarditis. So infections of the lining of the heart, infections in the spine. These infections require long-term IV antibiotics. So typically a PICC line is put in and the antibiotics are delivered there. Patients would have to sit in the hospital for about up to 6 to 7 weeks receiving IV antibiotics. Any patient, I don't care who you are, that has to be in the hospital 6 weeks, it's not going to be a good patient.
No.
They're feeling better after about day 10, but they still have to stay for the run of antibiotics. Up until, recently, residential treatment providers, inpatient treatment providers will not accept those patients into treatment because they have that PICC line put in because to manage it. So St. Luke's created this program partnering with Penn Foundation is what would it look like at about week 2? We're able to work with that patient and the infectious disease team and the internal medicine team to get that patient kind of hyped up, like, hey, treatment's possible, recovery, we've got this great program for you. And then with collaboration with the recovery specialist, transferring that patient to Penn Foundation. But then we bring in visiting nurses that will see the patient twice a week who will manage the PICC line, change the dressing, do any flushes that are needed. Patient can help administer their own IV antibiotic because just plug it in and kind of go, and go. And so now instead of sitting 6 weeks in a hospital getting nothing, they're able to go 2 weeks in the hospital, and then the last 4 weeks will be at Penn Foundation. So that, person-centered, patient-centered response is incredible, not only when you look at healthcare and you're saving acute care bed days, but you're actually giving that patient something that they really need.
Yeah, you're able to capitalize on someone being in this hospital setting for, like you said, 6-7 weeks and turn it into something beneficial for them rather than likely sitting in the hospital bed and going crazy. I know I would not do well in that environment. But I really like that you guys are approaching recovery, looking at the whole person, which is something you mentioned and was something I was going to bring up anyway. So thanks for covering that before I even had a chance to. What kind of success are you seeing in the patients that you guys have treated thus far in this substance use program? Or the reviews, I guess, from them?
Yeah, I think, one of the things and of the comments that we often receive from patients that we serve is that they feel like we really care about them and we care about helping them through this journey. And I think one of the challenges that patients experience over time is that stigma or how someone treated them when they came into the emergency department or a primary care or an urgent care setting, right? And so, one of our goals is to not have people feel that way.
Right.
We want them to feel comfortable getting care. We want them to come to us when they do need care because we know that, substance use disorders are chronic and a return to use is not uncommon. So we want people to feel comfortable in the sense that when they do have a recurrence of use, they do feel comfortable reaching back out to St. Luke's and saying, you know what, I need help. Whether that's inpatient, whether it's detox, or whether it's outpatient, that they know where to go to get that help. And I think that's really important. And we see a high volume of substance use disorder patients in our emergency departments on a regular basis. And so it's important that we're treating that when they're ready.
What is your, I guess, kind of highlight within your career at St. Luke's in the substance use field? Like, is there a moment for you that really stands out when working with a patient or anything along the lines of that you guys would want to share?
I could take that one.
Yeah.
For me, is that they recruited me and hired me. My position at St. Luke's is unique. It's probably the only one that exists that way in any type of major healthcare organization. I'm not a clinician. I'm not a provider. I'm not a social worker. To be honest, I don't really have a touchy-feely bone in my body. But I have this background, and that St. Luke's took that risk in hiring somebody with the ideas that I'm going to make their life miserable. I'm going to come into the ED and talk to providers, talk to nurses, make them follow a process, create a process that works for them, partner with them. The St. Luke's really wanted to take this journey, and they wanted to do it right. They wanted to be able to position the network in a way that aligned with the community resources instead of a healthcare institution just going out and doing their own thing. And so I think it was a bold statement as to really what they wanted to do. And so, working in politics and government most of my career to make this switch, I think that was amazing, where it's frustrating work at times, but it's so rewarding when you get to work with so many highly motivated, highly intelligent individuals. And then when you're able to connect with them and they're able to provide a program or a workflow that makes sense, and we answer the question, why are we doing it this way? And then it just benefits our patients and it benefits our patients' families. And so we get to see this change.
Yeah, I think for me, working most of my career outside of a health system, and then becoming part of a health system is something I kind of always envisioned, but wasn't sure would ever happen. And so, I really enjoy collaborating with the emergency department, with maternal fetal medicine, which we've had the opportunity to do. And when other service lines reach out to us with questions, or I don't know what to do with this patient, to me, that speaks volumes, because that wasn't something they were doing 5 years ago. And so I think also the opportunity to work with residents, to provide education to residents and fellows who are really just starting out their medical career. Layne does a lot of education with nurses, new graduate nurses. And I think being able to touch all of those pieces and educate people about substance use disorders, because you're not going to work in the healthcare field and not run into it. So, and it's something I think more recently in medical school they're focusing a little bit more on, but still it's not a large piece of what they do.
Right.
And so, last July, St. Luke's accepted our first 2 addiction medicine fellows. And so we have 3 more starting today. So I think, St. Luke's also investing in creating that fellowship program is also huge, and building a capacity to be able to take on more patients with a substance use disorder by having those physicians available to treat the patients we serve. And I think, again, just the success stories, right? When we hear positive stories from patients that we've worked with, when we see them, 2 and 3 years down the line and they're certified recovery specialists, or they're working in the field, or maybe they're just starting off and having a family. I think that's kind of what keeps us going, right? Because we also see a lot of overdoses, and
Right.
we see the negative, for lack of a better term, side of things, but there also are many positive things. And I think that's sometimes what's hard about the emergency department, right? They're always seeing people when they are at their worst, right? So they never see the end result in most cases. Whereas when you work in treatment and you work in more of the community programs, you get to see sort of that longer term result and the success that comes out of all of those emergency department visits that at some point ended up where that patient got connected to treatment and it was the right time for them.
I like that you guys have started to integrate the compassion and connection aspect all throughout the hospital setting and touching so many different parts of the system, and being able to change lives through medicine and through treatment models, but also through having that personal connection to people. I think that that's especially important in a recovery sort of setting. Amy and Layne, I just wanted to thank you guys so much for providing sort of a different insight as to what I'm usually getting here. It's really neat to hear the healthcare perspective of something, when a lot of the times, at least in my side of the field, we're hearing from individuals and families. So I really appreciate all that you guys have brought today. And if you need any resources, you can reach out to St. Luke's directly or on our website at wefightfentanyl.org. Education is prevention, and connection saves lives.